So a 45-year-old woman now, on page number 5, comes to the emergency department because of a change in mental status and hemiparesis of the right side. She said she was well 2 weeks earlier when she developed intermittent fevers, sore throat. She has suffered from several nosebleeds and gum bleeding over the last week. So again, you get some sense of a bleeding disorder. And always in young adults, this is always a problem because you need to think about leukemia. Again, because it infiltrates the bone marrow and destroys the platelets. So this patient had several nosebleed and gum bleeding over the last week. Her local internist evaluated her that morning. The complete blood count shows white blood cells 1,500. So please make a note of that. That's low. Hemoglobin is 7. That's low. So she's anemic and she's leukopenic, and the platelets are 32,000. So she has pancytopenia now. She is lethargic and is not moving her right side. So beside the pancytopenia, this person has something of a stroke syndrome. She's not moving her whole right side. Her temperature is high, 38.3, and blood pressure is 160/100. Examination of her eyes, nose, ears, and nose and throat is normal. Her neck is supple with no adenopathy. Her chest is clear, and her heart has a regular rate and rhythm with a normal S1 and S2. There is no hepatosplenomegaly or peripheral edema noted. Neurological examination shows that she is confused, oriented only once, has a right hemiparesis and upgoing toes on the right. She's uncooperative with sensory examination but withdraws to painful stimuli on the left. So this patient, we need to evaluate two things in her. What's really causing all of her issues? And it's likely, like we said before in the previous case, when you find a patient where you have all 3 cell lines decreased, pancytopenia, you think of two things: an acute leukemia or a plastic anemia, or sometimes even TTP, but that wouldn't present this way. It wouldn't present with all 3 cell lines down. Okay? So you think about really an acute leukemia or a plastic anemia. Now this patient has something more though. She came in with seemed to be a stroke syndrome. And in this patient, given her platelets of 32,000, you consider in her a central nervous system bleed. So a young patient that doesn't have any other risk factor for having a thrombotic stroke and platelets of 32,000, she has an intracranial bleed, probably involving the middle cerebral artery or something like that, because she's not mentating well. So that's your differential diagnosis. Is this a leukemia or an aplastic anemia? Your initial diagnostic plan should be just like before, plus to investigate what's going on in her brain. The peripheral smear is the one that's going to give you an early diagnosis and evidence of what's going on in this patient. And of course, sooner or later, you're going to have to look at her bone marrow. Now, let me say this again. Remember that I told you in the previous case that a lot of the acute leukemias present with low white cell count. So this is called a leukemic leukemia. You may not see the 30% blast in the peripheral smear, so this patient, you would more likely to find it in the bone marrow. Okay? Very good. There are also other ways that people with leukemia present with CNS bleeding. There's one more way, very important way. People that have myeloblastic leukemia, acute myeloblastic leukemia, a type called promyelocytic leukemia, M3, present with disseminated intravascular coagulation, a consumptive coagulopathy. So they bleed sometimes in the brain. A CNS bleed is a part of the syndrome sometimes. So in this case, yes, it may be the 32,000 platelets or it may be disseminated intravascular coagulation. This is why you see in their initial diagnostic plan, they're looking at the prothrombin time, the PTT, they're looking at fibrin split products, at fibrinogen, and so forth, to make sure that this patient doesn't have disseminated intravascular coagulation. So you get all this stuff back, and you find that in the peripheral smear, you find multiple immature myeloid cells seen with atypical folding pattern. Our rods are seen. Our rods mean myeloblastic leukemia, and they likely mean M3 or M2. So you almost made the diagnosis. So immature myeloid cells with a typical folding pattern and our rods. You made the diagnosis here. The PT and the PTT is a little bit elevated. So now you're thinking, well, could this be disseminated intravascular coagulation? You look at the fibrin degradation products, and they are decreased. I think the fibrinogen is decreased, rightly so, because if you have disseminated intravascular coagulation, fibrinogen is consumed, and the fibrin split products are over 400. This patient has also DIC. So the rest of the labs are normal. So it's likely that this patient has promyelocytic leukemia. Now, you're going to have to do, just like the patient before, staining and chromosomal analysis and all that stuff to document this. But promyelocytic leukemia, M3, is a very interesting leukemia because, one, it sometimes presents with disseminated intravascular coagulation. So the bleeding diathesis in this patient doesn't come from the low platelets, but comes from the disseminated intravascular coagulation. Number two, it is common to find our rods in this patient. Very common. So our rods look like this. Here's a myeloblast. Here's the nucleus. Now remember, if you were looking at a lymphoblast, the lymphoblast would look at something like this. Scant cytoplasm. Here's the nucleus. Here's the nucleus of the lymphoblast. And they look kind of dark because they're very homogeneous. A patient with, there you go, so scant cytoplasm. This is the only cytoplasm left. Look at this cytoplasm. Very, very extensive. And you look at this patient's nucleus and you find these granules called sometimes azurophilic granules. That's the difference between a myeloblast and a lymphoblast. The cytoplasm and the granules. And plus, this material outside in the cytoplasm sometimes that you find, especially in M3, this is the our rod. So that's what you should look for. So disseminated intravascular coagulation, our rods are common in M3. And there's one more thing that is very specific in these patients. It's that this leukemia has receptors for retinoic acid. So the receptors on the cells are retinoic acid receptors. So this is very important in the treatment of this patient with M3 because if you give derivatives of retinoic acid to this patient, these blasts proliferate. They proliferate, but they grow to normal cells, so they don't become aggressive. So you cure the leukemia by giving retinoic acid. I don't mean that the blasts proliferate and they become more blasts. They mature to normal cells. That's what I mean by giving retinoic acid. So that's the importance of knowing this M3, and that is the only type of acute myelogenous leukemia that you have to know. There's 7 of them. They're classified into 7 leukemias, myeloblastic leukemias, but this is the only one you have to know some specifics about. So that's what this patient had. And we want to look a little bit further down because we're worried that this patient also has the CNS bleed, and we want to know what we're going to do about this. And, of course, we consider getting a head CAT scan. The CAT scan is the first test to do always when you consider a CNS bleed. You don't have to do it with dye. It could be done without dye. So a head CT is the first thing to look for the bleed. And, of course, it shows a left intraparenchymal hemorrhage in the parietal lobe. This is consistent with the bleeding diathesis. And, of course, you stabilize the patient. You may have to intubate her to protect the airways and so forth. And, of course, you eventually consider to do bone marrow examination to look for the blasts and document that this is AML and what type it is. Now, if you compare AML to ALL, we said that ALL occurs in children. AML it occurs in middle-aged individuals, so about 40 to 50 years of age. The cells are bigger. These are the cells in AML. These are the cells in ALL. Smaller cells in ALL. So different age group. These people get treated as the patients in AL with induction therapy. That's the treatment initially. Now, if you look at the survival rate in patients with acute myelogenous leukemia about 30 years ago, less than 10% of patients lived with AML. Less than 10%. Now, if you do bone marrow transplant, that is the best treatment. The survival is anywhere from 55 to 60%. That's the survival after bone marrow transplant in patients with AML. So that's the treatment of choice if you could do it. You can't always do it. Sometimes patients always have comorbid conditions. They're older. But that's usually the treatment, the best treatment right now with bone marrow transplant. They have the best chance of survival. If you use chemo alone, induction, and then you do the chronic treatment, just like we did ALL, that mortality decreases, this survival rate, not mortality, decreases by about 10% or so. So there's a difference in bone marrow transplant survival. That's the best. If they ask you, what's the best treatment of this patient, where do we get the best results from? It's bone marrow transplant. Now, when they originally did the studies on bone marrow transplant, there's a good thing here. If you take the patient's own cells, own bone marrow, and you radiate it with monoclonal antibodies, kill off the bad cells, and then wait later and transplant the same bone marrow, homologous to the same patient, and you compare the same patient or another patient with AML, where you've taken another person's bone marrow and transplanted in that patient, so I'm comparing autologous, right, homologous, autologous bone marrow, so you're taking it from the same person versus another individual, compatible but another individual. When you transplant bone marrow from another individual in leukemia to the patient, these people have a better prognosis. So let me say this again. If you take somebody else's bone marrow and you transplant it in a patient with leukemia, the patient that will receive bone marrow from another healthy individual will have a better prognosis and will have at least about 5 to 7% more survival chance than a patient that you take the same bone marrow, you radiate it, kill off the bad cells, and transplant it back to the same patient. This phenomenon, you wouldn't expect that. You wouldn't expect that because you would expect more complications when you transplant somebody else's bone marrow in a patient. This phenomenon is called graft versus leukemia reaction. And it means that when you transplant healthy cells in a patient with leukemia, these healthy cells are aggressive and they fight off the leukemic cells. It seems that maybe the patient that has leukemia has lost this property, so they do worse. Okay? So graft versus leukemia reaction. You all should know that. Okay, very good. So that's the patient on the second case, and this patient had acute myelogenous leukemia, and eventually we said this is the treatment with bone marrow transplant. So I'm going to go on to the next case. We're on case number 3, and on page number 9, and this is a patient that came in with fatigue. And a 75-year-old guy comes to the office because of progressive fatigue over the last 3 months. So now you're getting a history of 3 months duration. You're not getting a history like before where we saw both of these patients presented abruptly within 1 week. This is over 3 months. In addition, the patient knows several episodes of upper respiratory tract infection over the last year, which is unusual for him. The patient also complains of fullness in his abdomen and states that his appetite has deteriorated, although he has not lost any weight. He denies fevers, chills, cough, or history of abdominal bleeding. Physical examination shows bilateral adenopathy in the cervical and supraclavicular chain. The lymph nodes are hard and non-tender. The largest is approximately about 3 centimeters. That's a big lymph node. His chest is clear and his heart has a regular rate and rhythm with a normal S1 and S2. His abdomen is soft and non-tender. A splenic edge is palpated about 5 centimeters below the left costal margin, and there's bilateral shoddy inguinal adenopathy and is present. The rectal examination is negative for fecal occult blood. So here's a guy, a 75-year-old man, that comes in with 3 months of this syndrome of fatigue, and you also notice that he's got lymphadenopathy and splenomegaly. So if this were to be some kind of leukemia, this would have to be a chronic leukemia. The chronic leukemia that occurs in older individuals is, of course, CLL. So if you think about it, ALL, the two lymphoblastic leukemias, occur at the two ends of age. ALL occurs in children. CLL occurs in older people, 60, 70 years of age. So if you're thinking about a lymphoblastic leukemia, if you're thinking about a leukemia, it has to be CLL. There's other things that occur also, though, that present this way, and one of them we tend to forget in older patients. It's Hodgkin and non-Hodgkin lymphoma. Now, especially Hodgkin lymphoma, we tend to think about it as a disease of young people. But in reality, Hodgkin lymphomas has a bimodal distribution. It has a peak at about 30 years of age, and then a second peak about 55, 60 years of age. So definitely think about Hodgkin's lymphoma in older people that present with lymphadenopathy and fatigue. This patient is 75 years of age, a little bit old, but definitely you should think about it. You should think about infectious mononucleosis, although it's rare for this to occur over 3 months, and especially in a person 75 years old, you would think that they were infected sometime before that. And also CMV infection, these mononucleosis-like syndromes, infectious mononucleosis, EBV and CMV, that occur usually in younger patients and children. So this is rare here. So definitely you should think about, in this patient, CLL and Hodgkin lymphoma should be at the top of your list. Again, the peripheral smear and the CBC will give you a lot of information. So you look for a complete blood count and you want a differential in this patient. And you eventually would want to get a bone marrow examination to make the definitive diagnosis. Always in leukemia, we said bone marrow examination is a definitive way to diagnose it. So what do you find in this patient? You look at his white cell count. It's 35,000 and definitely elevated. His hemoglobin is a little bit on the low side. His platelets are a little bit on the low side. And you look at the differential, which shows 80% mature lymphocytes. So look at this now. Most of the cells are mature lymphocytes. They're not blasts, not the blasts that we saw before in acute leukemias. This is how you say this is likely a chronic disease, plus the symptoms that the patient has. So mostly lymphocytes. Now, they went a step further. They saw that. They made the likely diagnosis of CLL, and they looked for a couple other things. They looked for a hemolytic anemia with a direct Coombs test, because we know that CLL presents as fatigue with high white cell count, with the lymphoblasts being elevated, with the lymphocytes being elevated, but also these lymphocytes produce antibodies against the platelets and against the red cells. So the other thing that is characteristic about CLL is a hemolytic anemia and an immune thrombocytopenia. Please mark this and make a note of it. It does not cause anemia and low platelet count like the acute leukemias where they infiltrate the bone marrow. This is antibody-induced. That's why in this case, the direct Coombs test was positive. They did a chest x-ray to look for lymphadenopathy, make sure this patient doesn't have Hodgkin's or non-Hodgkin's lymphoma, they should see mediastinal lymphadenopathy, and they found that to be normal. And they did a bone marrow examination and now found in this patient diffuse infiltration with mature appearing lymphocytes, myeloid and erythroid maturation appear normal. So diffuse infiltration, mature appearing lymphocytes, that's the definition of CLL. So let me go over this again. Chronic lymphocytic leukemia presents in older individuals. 90% of the cases occur in patients over 60 years of age. They are a chronic form of leukemia, so they don't have very aggressive symptoms. They don't have aggressive symptoms. They occur over a long period of time, weeks to sometimes months. They present with anemia and thrombocytopenia sometimes that is immune-mediated, and also with chronic infections, because these lymphocytes don't fight off infections that well. So those are the characteristics of CLL. About 30,000 white cells, 40,000 white cells, that's the typical patient with CLL. So that's what you should consider. Well, what do we do with these patients that have CLL? That's a good question. That's a good question. After you do the cell markers and cytogenetics and you document it, the treatment plan, some people say if it's stage 1 and 2, you don't need to know the stages, but if these patients have only the white cell count that is elevated, and remember, it doesn't have a lot of symptoms, so sometimes it's picked up on a routine examination. They do a CBC and they found that this patient has 40,000 white cells, minimal symptoms. So it's a common way that CLL presents. But if it's early stage with no symptoms other than the white cell elevation, then most people say do not treat the patient. Do not treat the patient, because if you give them the treatment, chlorambucil and prednisone, they do just as well as when they're not treated. They've shown this in studies. Now, patients that have anemia, though, and thrombocytopenia and splenomegaly, they tell you, well, they're likely to benefit for chlorambucil and prednisone. Okay? So let me say this again. If they ask you leukemia, that is the most benign leukemia at CLL. In fact, a lot of people say don't treat this disease. They do just as good, and they die of something else. They're older individuals, in fact. They die of something else other than their CLL. So that's the bottom line in this case. You don't have to know about the chlorambucil and prednisone. You do have to know, though, about the infections that this disease causes and the immune thrombocytopenia and the immune hemolytic anemia. So I'm going to stop right there, and we'll take a short break and come back.